Okay, so welcome back, everybody. Just echoing Dr. Veenstra van der Wille's welcome comments. I also just wanted to quickly highlight, we have a new AV system here in the auditorium, and I'm hoping that out there in Zoomland, you guys can see the difference. But I just want to really give a massive thank you to Key and Simon for their hard work in making this happen for us. So thank you so very much. Okay, so just before we get started with Dr. Ford's wonderful presentation, I just want to make a note that next week Grand Rounds will be fully remote, and they will be given by Dr. Ana Abreu Lanza, who is the Vice Dean and Professor of Social Work at the School of Social Work here at Columbia University. And this talk is going to be hosted by the Office of Equity, Diversion, and Inclusion in recognition of Hispanic Heritage Month. And the title of Dr. Abreu Lanza's talk will be The Latino Population, Thoughts on Health Status and Diversity in Higher Education. And so before I introduce today's speaker, I just want to go through the run of show. I'm sure most of you are familiar with it, but particularly those of you out there attending by Zoom. First of all, please post your questions in the Q&A, not the chat feature. If you are a trainee, please note trainee at the end of your comment, as we would like to prioritize those questions. And as always, we really encourage folks who are on Zoom to ask the questions in person, and we can promote you temporarily to host or to join the panel, and you can speak directly here with our speaker. And so just note that on the end of your question if you'd like to ask it yourself. And then lastly, a little change. Today, lunch will be served at 12:20 in the multipurpose room, which is room 6002 of this building on the 6th floor. So it's not going to be outside, but upstairs. Okie doke. Okay, so today's speaker. Today's rounds are given by Dr. Elizabeth Ford, who is the clinical director, the deputy director of the New York State Psychiatric Institute, and also associate professor and director of mental health and criminal justice initiatives for Columbia University Department of Psychiatry. She is involved in both medical school and residency education here at Columbia, and has co-founded and chairs the Psychiatry Department's Work Group for Justice-Involved Behavioral Health. Dr. Ford received her bachelor's degree from Yale University and her medical training from the University of Virginia before completing her psychiatric residency and fellowship training at New York University School of Medicine. Following which she has devoted most of her career, if not all of it, to the care and advocacy of individuals involved in New York's criminal justice system. At NYU, she served as the director of the Division of Forensic Psychiatry at Bellevue Hospital, as well as the training director for the NYU Forensic Psychiatry Fellowship, before assuming the role of chief of psychiatry for New York City's Health and Hospitals Correctional Health Services in the New York City jail system, and that includes Rikers Island. An easy job if ever there was one. So now Dr. Ford joins us here, but she has taught and written extensively about topics related to increasing awareness about and knowledge of healthcare in confinement settings, and encouraging mental health professionals to become more involved in reducing the criminalization of mental illness. In 2017, she published a critically acclaimed memoir entitled Sometimes Amazing Things Happen, Heartbreak and Hope on the Bellevue Hospital Prison Ward. She has also published widely in peer-reviewed academic journals such as Psychiatric Services, the Journal of American Academy of Psychiatry and the Law, and the Journal of Correctional Healthcare. Dr. Ford has contributed significant work for the American Psychiatric Association with respect to psychiatric care in jails and prisons, and has received numerous awards for these endeavors, most recently awarded the Judge Stephen Gross Memorial Award Council of State Governments, Judges and Psychiatrists Leadership Initiative, given to one psychiatrist each year who has demonstrated extraordinary leadership in improving the lives of people with behavioral health needs who are involved in the criminal justice system. The title of Dr. Ford's talk today is Uncuffed, Assessing the Impact of Criminal Justice Status on Emergency Psychiatric Care. Please welcome me in joining Dr. Ford today.
Thank you, Dr. Elkington. I may need some help figuring out the slides. That's the only thing. Here we go. Are we good? Okay. Hi, everyone. Thank you very much for that introduction. And I can appreciate that I'm on a time crunch, and I've asked Kate to please stand up when I need to get moving a little bit faster. I also, full disclosure, accepted this invitation in January before I was in my current position as clinical director, which is totally fine. But I am grateful to be recognizing a few more faces in the audience today than I would have otherwise. And it also will explain a little bit about why what I'm going to talk about continues to be a work in progress, because it is work done when I was employed with Health and Hospitals until the end of March of this year. I'm also going to assume that many, if not all of the audience have a very, if not a very comprehensive, at least a somewhat basic understanding of the workflow in an emergency setting, the ideas around triage and assessment and disposition. And if that is an incorrect assumption, I'm happy to field questions about some of those details towards the end. But what I'm talking about is a pretty complicated topic, and I'm going to try not to get too much in the weeds, but it's hard to also talk about the interface of criminal justice and mental health without getting into some of the details, because that's where most of the problems lie. So what I'm hoping to do today is to first explain the current clinical and legal practices around emergency psychiatric evaluations for people under arrest in New York City. So those are people who have been formally taken into custody by the NYPD. Then describe a QI initiative at Health and Hospitals that's hopefully soon to continue, but was aimed at better understanding the population and improving patient-centered care for that population. And also just a note, I do want to emphasize, and hopefully I will throughout the discussion today, the importance of quality improvement as an actual tool for research and scientific understanding. I largely have worked in very public systems where almost everybody is overwhelmed with their clinical responsibilities and has very little time or resource allocation to study what they are doing and to improve their care internally. And I think that's a really important part of the clinical work that we all should be doing. And then I'm going to discuss what has happened with the use of some of the preliminary data from these findings to try to advocate across various agencies in the city to expedite a particular legal intervention that has profound clinical consequences. Okay, here we go. So first up, the legal landscape. So with, you can see my cursor. So in New York City, and this is just New York City, when someone is arrested, they're taken first into custody and a clock starts, a 24-hour clock starts for them to get to the end, which is arraignment. And that is when the individual sees a judge for the first time. And the time between arrest and arraignment, the person cannot be released from custody. Okay, so once the police have actually arrested someone, you can't get out of that situation until you see a judge. That is almost unique in New York State as compared to the rest of the country, where when you are arrested, typically people are booked directly into jail, and then they'll see the judge to talk about getting released. And this arraignment clock, this 24-hour clock, was, I think it was litigated in the early 90s. Yeah, so the time to arraignment in New York City is supposed to be 24 hours or less. The reality is somewhat different than that, and it has waxed and waned based on various factors, including the pandemic. But I want to highlight, because this relates to what I think could happen again. In 1990, Legal Aid filed 9,000 habeas corpus petitions for people who were waiting arraignment for incredible periods of time. For example, a vendor selling an umbrella who waited for 5 or 6 days for arraignment. And then so People v. Roundtree was the case that essentially identified this 24-hour clock. So keep the clock in mind, because during that period from arrest, at least through to just before arraignment, at any point the police can bring someone into a psychiatric emergency room, into a CPEP, or into a medical ED for care. And the NYPD policies around who should be brought into care are vague, as many policies are. So they're brought in for lots of different reasons. But what important, and you can see some of what happens. So people are in handcuffs, sometimes shackles, which are leg cuffs. There are at least 2 accompanying officers. Sometimes they're accompanied in an ambulance. But what happens here is that 24-hour clock stops. So the moment that someone is brought into the hospital, the NYPD and the court system in the city have, it's not written into law, but have practiced that this 24-hour clock is indefinitely paused. So no one's tracking that time anymore. No one's working to expedite that arraignment. Again, a reminder, arraignment is when people can get released. Additionally, complicating this is that when you're in that pre-arraignment phase, if you do not have enough money to hire your own attorney, you have no legal representation. So there's no one in the law system advocating for you to get to arraignment faster. And because of the complexity of hospitals and the criminal justice system, the mental hygiene legal service, which typically represents people who are in hospitals, has not taken a firm stand on whether they represent these particular individuals or not. And just to note that in New York, actually Michael Compton and Leah Pope, who are researchers here at Columbia, found that almost all people arrested and identified as having a serious mental disorder over a 3-year period had been charged with a misdemeanor or a nonviolent felony, which is important because now, after bail reform in New York, people charged with misdemeanors or nonviolent felonies are presumed to be released, actually. So again, we're talking about a population of individuals who most likely will be released at arraignment. And so that arraignment point is pretty important. So that's a little bit of the legal stuff. On the clinical side, this is a very rough description of the workflow in an emergency room, very rough. And I see Dr. Lawrence in the audience, so he's going to know that this is super rough. But I just want to highlight that at each of these moments, being under arrest, the state of being under arrest complicates the clinical picture. So on the triage side, the person is in restraints. That impacts the way an individual communicates with the person evaluating them. That impacts the way the evaluator communicates with the person. It obviously indicates the way someone can physically move. There are accompanying officers who are frequently right next to the person, which clearly impacts confidentiality. It also impacts the milieu of the entire emergency room. There's confusion about how to manage acute symptoms. So can people in police custody get a benzodiazepine for their anxiety? Can they get a sleep medication? Are there certain medications that are not allowed in the criminal justice system? The answer is no, but people don't know that. And then what happens if someone needs to be restrained, especially someone who is already restrained? So frequently, clinicians will ask the police to do extra restraints on that individual in lieu of placing wrist and ankle restraints. Let's see, here we go. In terms of the assessment, there's just general confusion. What are we actually assessing in the emergency room? This person is coming in. Am I supposed to figure out if they're stable for arraignment? That's really not a thing. Can I call family? Do I have access to records? Can I talk to the cops about anything that's going on with the patient? These all have answers, and we can talk about that later. And then in terms of diagnosis, there are, as you can imagine, a whole host of factors that go into diagnosing someone in an acute crisis situation. And if you add to that being in handcuffs, being watched by police, being charged with something, being taken from your community, and having incredible anxiety about what's going to happen next, that all influences how someone behaves and their mental status. And it also influences the medical decision-making of the providers. And then in terms of disposition planning, it gets even more complicated because you are assessing whether you should basically send someone over with the police and have them move into the criminal justice system for whatever awaits them there, or should you keep them in the clinical emergency room and struggle with all of the issues that I just described. And I'll talk about that in a little bit more. And then there is across the board, this is not specific to New York City at all, but there's individual, institutional, and systemic professional bias in every setting that I've ever heard about or worked in, related not just to people who are in the criminal justice system, but to people who are Black and people who are poor. Kate mentioned the Justice Involved Behavioral Health Work Group, and she is one of the leaders there, so thank you. I wanted to play for you a couple of very quick sound bites from individuals who have experienced this system. We held a symposium in June that was much longer than this and that was not specifically related on this topic, but I think it's important to hear the voices of those. I would show you the videos, but the AV system was not as good as it is today, so the video capture didn't work so well. Let's see.
The other spectrum of mental illness. I was a guy who hid his symptoms all the time. I never spoke about my mental illness, not with my family, not with my friends, and certainly not with the authorities after I was arrested. I was raised, I'm Puerto Rican. I was raised in a housing project on the west side of Manhattan. And in the culture I was raised in, there was no such thing as mental illness. You were not sick, you were just a punk who couldn't take it or couldn't handle life. And when I absorbed that later in life, I never wanted to talk about what was happening to me and how my behavior was becoming bizarre. When I was arrested, the police couldn't even get into my apartment because I had turned into a hoarder. And I had so many garbage bags in my apartment that they couldn't open the front door. They had to rely on me to squeeze myself out of the apartment so they could arrest me.
So that was John. And by the way, all of these individuals have given consent to have their voices and their stories played today.
I heard in the earlier panel them speaking about trauma, childhood traumas, right? I don't know when people stop being themselves. I don't know at what point. I know I stopped being myself at 12 years old. I didn't know that I had any type of anything, but what I do know is that when I was taken to hospitals, I received a diagnosis of schizophrenia, the paranoid type, and that's a label that goes with me everywhere I go. We talked about the labels earlier, right? That's not my diagnosis now, and that's definitely not who I am. But we have to be careful of how we are addressing individuals. We have to be. So crisis looks different for everyone. That's just what I have to say about it.
In that environment, and that's a big cultural problem in every jail. I never worked prisons, but I'm assuming the same thing.
Sorry, I'm just
Got
gonna.
it. Thank you. Derek, did you want to speak?
Prison of young black males, right? So we can all agree to that. So it would be the same barrier to young black males asking for help anywhere. They generally feel, I was young at one time, they generally feel, particularly when you've been arrested in the earlier stages, that everybody is oppositional. So I come in from the street where generally my neighborhood, I grew up in Bed-Stuy, so at that time it wasn't Tony, it was over-policed. And then I felt oppressed. And then I got to Rikers Island and all I seen was a bunch of police. And I felt a little bit more oppression. And then I got in.
So that was Derek, and prior to Derek was Tony. So those are all individuals who've been through some of the systems that we've just described.
The other spectrum
I heard
of
in
mental
the earlier
illness.
panel
I was
them
a guy
speaking
who
about
hit
trauma, childhood traumas, right?
All right. Let's see, how do I get to the next slide here? It's not, let's see where you're going. Hold on. Let's try this. Okay, here we go. All right. How do I describe this? Okay, so these are, these cogs here represent just some of the systems that are at play in that one decision in the emergency room about whether to release someone police custody or not. So the giant one is psychiatry. Up top is the Unified Court System, the Office of Court Administration. So they manage the courts. They also manage MHLS, the Mental Hygiene Legal Service, the NYPD, District Attorney's Office, and the Legal Aid Society, which is not the only public defender agency in the city. But I wanted to sort of represent that. These are quotes here from providers in psychiatric emergency rooms throughout the city. I've all received in the past year from various locations and not just throughout the health and hospital system. So I just wanted to highlight that it's an ongoing problem, that there's confusion about how to take care of these individuals. So every time someone comes in under arrest, it's a huge mess and we have no idea what to do. They don't have lawyers, so we shouldn't even be talking to them. The cops had obviously beat him up, so I admitted him just to keep him safe. They'll get care in jail, so as long as they aren't dying, there's nothing for us to do. Someone in police custody can't be admitted on a voluntary status, which I'll just correct here because that's not true. And then a quick question, I just received this last week, maybe not such a quick answer. Any suggestions as to what to do? We have a patient in CPEP who's in leg shackles and has both hands handcuffed, one to each side rail. The MD asked the officer to remove one handcuff and the NYPD refused. And then the last one, which I've heard repeatedly over the past 2 decades that almost everyone who comes in with the police is malingering. So what I think I alluded to before, and this is a complicated slide, apologies, but at the top here, the clinical decision about whether to admit somebody to an inpatient unit or not who is in custody has a lot of legal ramifications. So if you decide to admit the person based on clinical reasons alone, great. They can have a hospital or a bedside arraignment, and these arraignments have that capacity has expanded exponentially since the pandemic. So video arraignments prior to COVID-19 rarely happened, and now they happen now, and the courts have accepted that it's safe enough to do. So they can be arraigned, and then if they get released from custody, which happens the vast majority of the time, then they can get access to the, not tons of, but the civilian inpatient beds. They can get access to civilian follow-up and outpatient care. If they get remanded, which means booked into jail, then if they're a man, they have access to about 55 forensic psychiatry inpatient beds there. If they're a woman, and this is where the story gets particularly horrible, there is no care available at all in the city at this moment. It used to be at Elmhurst Hospital. That shut down in March of 2020 for reasons you can understand. And the agencies involved that we just described, including also the Department of Corrections, have not figured out a way to provide inpatient psychiatric care to women. So what happens right now is that they sit in emergency rooms. Now, so that's what happens. So, but the care is all kept in the hospital. If the decision is made to discharge the individual, then they'll accompany the police to the criminal courthouse where they'll get arraigned. Same kinds of decisions made, released or remanded. If they're released, they're released, which is great, free to do whatever they want, but also tricky if you're the clinician up here assessing someone who says that they may be suicidal or that they're very depressed, and you're not sure what's going to happen down here, because it's really up to them to seek care. Now, most of the emergency rooms I'm familiar with, including the one at Columbia, have some version of a letter like this that the physicians fill out and give to the, well, with consent, they'll give it to the police, or they'll give it to, put in an envelope, and it's delivered to the judge. And it's basically telling the judge, hey, if you decide, not hey, but if you decide to release this person, they might still need care. So please be aware of that. If they get booked into jail, please have them evaluated by the healthcare service there. The problem is that, at least in Manhattan, no judge has ever seen this piece of paper. So I canvassed them last year as part of my job at Health and Hospitals and showed this piece of paper to them. They're like, I don't know what this is. So that's a problem. Okay, so there's some problems here. Hopefully I'm relaying that. So the second part of this is to talk about, over the course of about a year or so, a quality improvement project that New York City Health and Hospitals undertook to try to better understand this dynamic with data, to better understand the population of individuals under arrest. Because believe it or not, even though Health and Hospitals, since at least 1896, has taken care of people in police custody in their emergency rooms, they have not, until this study was created, figured out a way to know who is in police custody from a population level. So now they do, which is good. But in any case, Sarah was the prime statistician on this study, and then Joanne is in the general counsel's office. Big shout out to the IT and EPIC support teams. Very important. So electronic health records, I think, are one of the most important public health interventions we have. And then a shout out to inter-institutional academic collaboration. There were a number of trainees from different institutions who also were working on this project. And also, this continues to be so I left that job in March, end of March of 2023. I was the PI on the project. It went through the Brainy IRB. I had to close that because there was, to my prior comment, there was not the capacity to continue this kind of level of work once I left. We're working on a data use agreement now, so that can continue. But there's been a pause since the end of March. All right, so with any QI project, what are you trying to improve? Like what's the thing that needs to be improved? There are a lot that I've just mentioned. I'll just highlight a few of them here. So the lack of standardized guidance, patients who are waiting in the psychiatric emergency room in handcuffs for care, the impact of the officers in the emergency rooms, and which I'll highlight shortly, the lack of access to inpatient psychiatric care. So I won't go through this whole slide, but up here are some of the risks of waiting in EDs. There's a ton of literature about the harm that can come for board time or dwell time. And a lot of that's done in medical emergency departments. And New York City is pretty fortunate that we have a wealth of psychiatric EDs and CPEPs. Most places in this country do not. And so psychiatric care is delivered in a straight up emergency room. There was one study I think it was in England, that showed that there was a dose-dependent relationship, dwell time in the emergency room after 5 hours, a dose-dependent relationship with all-cause mortality 30 days later. So what does the literature say about people in police custody receiving psychiatric evaluations in emergency rooms? Like pretty much nothing, which is also part of what we were trying to identify at least some baseline data in this project. There is some work done in the 1990s, including from New York, that talk about patients referred by the police, but it's complex because the police bring a lot of people to emergency rooms who are in fact not in custody. And so that whole population is not accurately defining people under arrest. More recent work is largely international. There are complexities there because international healthcare and international criminal justice systems are dramatically different than the United States. And then what we have seen, again, in medical ED settings for medical care patients, some of those findings include things like allocation of medical care being based on the perception of a patient's criminality, reduced confidentiality and procedures related to informed consent, longer lengths of stay in emergency rooms for people brought in by police, the impact of law enforcement on the delivery of care, and then I just noted a survey of surgical residents. It was a small sample that noted providing care to incarcerated patients or patients under arrest. Those are two different populations. Showed that the majority of residents felt that the holding areas for patients in criminal justice custody provided substandard patient care. So the goals of the project, again, to characterize the population. We still have a lot of work to do on that, but we'll talk about that in a second. And then the next was to just try to do an overview assessment comparing, and I'm calling them civilians. It's not, I don't know what else, but it's just sort of convenient. People who aren't under arrest. So civilians compared to people who are under arrest with respect to how they're diagnosed, what their dispositions are, meaning are they discharged, are they admitted, are they put on a 72-hour hold, do they go to the medical, are they admitted to medicine, and then also their length of stay in the psychiatric emergency room. Okay, so apropos of my earlier comment, the first challenge was trying to find out who's under arrest, right? So it might seem like a pretty simple request. In fact, in most emergency rooms, there's a checkbox that not these, but there's a checkbox that says, is the person under arrest, yes or no? Almost none of those are filled out. So that's a problem. And so this is the EPIC, this is a part of the EPIC system in health and hospitals. These are some of the questions that are asked on the assessment in the psychiatric emergency rooms: custody status, whether they were brought in by the NYPD, who sent them, law enforcement details, criminal justice, and juvenile justice status. So one might think that if these were all checked appropriately, it would be pretty easy to find out. The problem is that most providers, understandably, don't really know what any of this stuff means. So someone will check with DOC, which means with the Department of Correction, not the doctor on call. And then they'll also say brought in by NYPD. Those are mutually exclusive. Those are two different organizations in this city. So they can't happen together. Similarly, if it says with DOC and arrest, you're not sure if they've passed through arraignment. Anyways, there are all these sorts of complexities around identifying these. So what the IT team and EPIC, and I was providing the clinical consultation around it, is we put all these sort of scenarios and models into this bucket to define the population who were, quote, under arrest. So you had to be in police custody, you had to have been sent by the NYPD and brought in by NYPD, but you couldn't be with DOC. You couldn't be an EDP, which is, there's language, I know, but emotionally disturbed person. So that's when the police bring in somebody, but they're not under arrest. You can't have been arraigned. Most people don't even know what arraigned means. You can't be coming in on an AOT order. You can't be coming in from the courts, like all these you can't be's. But when you throw this all in, we got a pretty good estimate of the population of people who are under arrest. And so that, I think, is a big win for the whole system. And now there's a report that can be run for all of the emergency rooms, and they can be tracking various variables and care related to this particular population. All right, so for this quality study, we started with pulling over 91,000 records of adults who had received a psychiatric evaluation at one of the 12 psych emergency, I think it's 12, 11 psychiatric EDs or CPEPs through the health and hospital system from January 1st, 2021 through September 30th, 2022. The end date was a convenience date because of some scheduling issues. But we tried to pick a sample that was at least a little bit further away from the pandemic crisis. We excluded a number of records for some of these various reasons and came up with a final sample of 82,417 records. That is a gigantic database of clinical information, just FYI. And we pulled again, this was designed for quality, not specifically for a research study. So we pulled variables that we thought would be most helpful for improving some of the quality measures we talked about before. So some demographic variables, primary psychiatric diagnoses. There were like 9,000 of those different kinds in the records. A lot of cleaning went on there. The admission time and date, their legal status. So these relate to, let's see, can you see this? These relate to the mental hygiene legal statute codes. So this would be a 72-hour hold, 940. This would be a voluntary admission. 913, 939 is an emergency admission, and 927 is a 2PC or an involuntary admission. And then what their disposition was. Okay. I have a graph that shows this too, but I just wanted to show you that there are some numbers up here. So age, sex, race, ethnicity, and housing. Now these are the way they're categorized in the health and hospital system. So we had to use those categories. You'll note that this is particularly binary, which is challenging. But if you compare the under arrest population and the civilian population, they were significantly different across all of these categories, except for housing. And we didn't actually end up sticking with the housing variable because you'll notice that the unknown was about half or over half for that. So that was not a reliable variable. And in graph form, if I can get to it, there we go. This just graphically shows, for those who don't like looking at all those numbers, you can see that Black men were overrepresented in the NYPD population, and that the NYPD population tended to be a little bit younger. Sorry, there's a hitch on this mouse. Okay, so overall, about 8% of people evaluated across the system in the psychiatric emergency rooms are under arrest. That may not be earth-shattering, but it's the first time that I think the system is aware of an actual percentage about that. And that's useful when you're planning for programs. They're more likely to be male, younger, and Black, and that is consistent with the population of people arrested in New York City. So this is the New York City population here. By race, I know these are particularly challenging race ethnicity categories. Pay particular attention, if you will, to the Black and the orange pieces of the pie. So New York City population is about 24% Black, but when you get to people arrested, it doubles. And then when you get to people detained, it increases again. When you look at the orange piece of the pie, white individuals represent about a third of the population, and that drops by over half when you talk about the group who was arrested, and then it continues to drop with jail detentions. So we looked at, so we just talked about a little demographics, diagnostic characteristics. There was, because the sample was pretty large, a lot was statistically significant. All of these highlighted pieces here. The only diagnoses that didn't come out as significant in terms of the under arrest and civilian populations were bipolar disorder, personality disorders, and stress disorders. And then down here we grouped, we created an SMI group that included schizophrenia spectrum, bipolar disorder, and depressive disorder. I had wanted to include PTSD as well in this, but the data was not reliable enough around that. So what this looks like, so anyways, this is what it looks like in graph form, and then I'll just summarize it for you in a second. So people under arrest are less likely to be diagnosed with all mental disorders, including serious mental illness, except for personality and stress disorders. They were less likely to be diagnosed with those, except it wasn't significant. Stress disorders, by the way, included adjustment disorder, which was a huge part of that bucket. Interestingly, 28% of people under arrest received no psychiatric diagnosis compared to 14% for those who were not under arrest, and people under arrest were less likely to receive a substance use diagnosis. I was surprised. We were all somewhat surprised by this finding, given that in the literature, people under arrest generally have been found to have higher rates of both substance use disorder and mental health diagnoses compared to people who are not under arrest. So maybe someone will ask me about that in the questions. Okay, so let's see, demographics, diagnosis, disposition. So whether they were, again, if they were admitted on a 72-hour hold, that's an extended observation unit, which only is allowable in a CPEP. If they were admitted to an inpatient psychiatry unit, in any of those voluntary emergency or involuntary standards that I was talking about, whether they admitted to a medical unit and whether they were discharged. Discharge was the reference here, and you can see that these were all statistically significant, and that inpatient psychiatry and medical admission was more common for people not under arrest, and people who were under arrest. It was a little more common to be in the EOU. Down here, so this is the mean and median length of stay in the emergency room. So 13 hours for people who are civilian, 8 hours for people under arrest. This totally shocked me, given that I continue to hear, again, even like last week, about people waiting in emergency rooms for days. So this I need to work on a little bit more to figure that out. But the median length, the assessment here is the median length of stay is 5 hours shorter for people under arrest. We talked about the observation. And in some ways, this does make sense if you believe that people in police custody are prioritized for triage, which I think generally happens across the emergency rooms. There's incentive to get people in police custody out of that clinical space, and are diagnosed, and if you believe that they're diagnosed less frequently with serious mental illness. I'm not like totally convinced about that quite yet, but we'll see about that. So then we did stratified linear regression models around a couple of these variables by demographics, just to see like how much does this actually impact the length of stay in an emergency room. So for age, sex, and race, ethnicity, what you're looking at here is that people in, let's take people who are 45 years and older, which in some correctional settings is considered geriatric. There's a change in, so if you're under arrest and you are greater than 45 years old, you stay in the emergency department 18 minutes less than civilians. Okay. If you are, let's see, a man and you are under arrest, you stay 19 minutes less. And that's highly significant statistically, but clinically, I mean, I don't know. I think it's hard to make an argument that 20 minutes in a length of stay differential is that critical. And then we did the same thing with diagnosis, and you can see here these someone with schizophrenia spectrum disorder who is under arrest will stay in an emergency department on average almost 49 minutes longer than somebody who's not under arrest. Again, some of these minutes are higher than the slide we just previously saw, but I'm still struggling to make a compelling argument that this represents a significant difference in length of stay. Okay. Oops, here we go. What we did find, so that we looked at that and then have started, and this is where things sort of stopped at the end of March, but we started to dig a little bit deeper and to do a little bit more cross-referencing around issues related to disposition. And what we found is that for people under arrest who were admitted to psychiatry. So they have already been determined by the clinical staff in the CPEP that they need an admission. And they need admission so much that the CPEP and the hospital staff are willing to keep that person in handcuffs with police custody in the emergency room for however long that takes, because they are so sick. And they wait on average 8 hours longer in the psychiatric emergency room than individuals who are not in custody. But the range is huge, so an hour to over 2 weeks. And based on discussion with CPEP and PsychED directors and my own clinical experience working in CPEPs, the wait time is typically related to delays in arraignment. What a little bit of diving into the data that happened before I left actually showed that there might be some worsening of this problem over the course of our data collection, so over the course of 2021 into 22. And my guess is, from what I'm hearing, that it might be getting even worse now in 2023. But from January to September of 2022, a quarter of people brought into the emergency room who were under arrest were evaluated to needed admission. That's a pretty high percentage. If you compare that to the same 9-month period in 2021, it was only 10%. So that to me indicates that of the people the cops are bringing in, they are sicker. They're generally appearing to be sicker. And then preliminary analysis toward the latter part of 2022 indicated the average length of stay for women in custody is getting progressively longer. This should come as no shock, since there continues to be no hospital for those individuals. And then, as I mentioned before, the study was closed, but just waiting for the DUA between Health and Hospitals in Columbia to be signed, and then we'll proceed. Also would love to have anybody who's interested sort of be involved in what I imagine is going to be several years of work with that data set. So what happened? What does all this mean? I think that it brings up a lot of questions, certainly. But one of the things that the data supports, and that those of us who work, I don't work there anymore, but people who work in the emergency rooms continue to report, is that there's really not great access to inpatient care for people who are in custody. And even if you're a man, and there are those Bellevue Hospital units, those units are run by the Department of Correction, not by the NYPD. In 1990, the two commissioners were the same person. And so there was an agreement that the Department of Correction could sort of temporarily house people in NYPD custody. But as the need for hospital beds for the jail population has grown, there are really no beds for the men in police custody at Bellevue anymore. So for practical purposes, you can sort of think there's really not inpatient care anymore. So what could you do? What could we do? So one idea is to reopen Elmhurst for the women. That initiative has been ongoing for several years now and has involved multiple agencies. And I'll just leave it at that. Patients who are in NYPD custody could be admitted to civilian units. There is nothing in NYPD guidance or state law that prohibits that. I will tell you that I am aware of no hospital in the city that has been willing to do that yet. We could create a psychiatric unit specifically for people in NYPD custody. That could be another option. Huge resource investment. Okay. Legal aid could file another class action lawsuit. Or actually, all of these things could happen. I think the one that's the most reasonable and feasible and that doesn't cost any resources at all is to just expedite arraignment for people who are in the emergency rooms. Because again, once you get to that arraignment point, if you're released, the civilian world opens up. If you're remanded, which again is a very small percentage of people, if you're a man, can get maybe access to the Bellevue Hospital units, you get incredible advocacy from the correctional health services in the jail system for your care. So you have a care provider who's still taking care of you. So arraignment is that really critical legal intervention that I'm talking about. And psychiatrists and medical professionals generally don't advocate for legal changes publicly. And I think this is an intervention where maybe we should. So here's some challenges to expediting arraignment, just a few. There are many more, but healthcare staff can't share information about a patient with law enforcement or the court system without consent. That's pretty understandable. Someone in custody, as I hope can imagine, may be less willing to provide consent for information to be released to anybody. So you may be aware that you're the doctor and you're not part of that system, but to the patient, you're still part of the system. And so there's really limited trust there. There's confusion amongst the courts, thinking they actually can't arraign someone until someone has been moved to an inpatient unit. But then the hospitals think that they can't admit someone until they've been arraigned. Then depending on the borough, video arraignments for patients in the emergency room are only scheduled once a week. So if you come in on a Tuesday and arraignments are Mondays, you're sitting around waiting until the next Monday. Now, it's a small volume of people. I mean, it's not any one person, I think, is this is critical for, but it's about 500 people a year who meet this inpatient admission criteria and are in this pre-arraignment phase. And both, the emergency mental health system and the court system manage hundreds of thousands of people every year. So 500 probably to many seems like not that much of a priority. I think that's misguided. And then the system that's most interested in expediting arraignment actually may be the healthcare system, but we generally have limited knowledge about or influence with law enforcement or the courts. So I'm going to play for you. This is one of the assistant commissioners in the NYPD who attended our conference. I just want to play you a little bit of a snippet from her, and then show you a proposal that's been pitched around.
And I always say, everyone should join us in that conversation, because we hold on to someone for, 30 minutes, and then we turn them over to the next system. And so in that statement, every other system is implicated, from the emergency drop-off to the decision to evaluate. All of those things are involved, and so I'm not trying to lessen the impact of policing and what happens when someone comes up against that system. But I'm saying to you, it is a connected system, and we all hold each other accountable, and we are all responsible, because that person.
Yeah, I think I agree with her.
And I always say, everyone should join.
All right, so a proposal that has been seen by a lot of those agencies that we talked about earlier in the discussion, but has not been picked up by anybody quite yet, and I think that has to do with politics, is a half-day problem-solving session to ensure that everyone in police custody awaiting inpatient admission is arraigned as quickly as possible. Again, small number of people, doesn't require any extra resources. There are plenty of staff who could pick up a phone, all that stuff can happen. The stakeholders, the particular stakeholders, I think, who relate to this include the NYPD, the Office of Court Administration, the Mayor's Office of Criminal Justice, MOCJ, Health and Hospitals, OMH, the Defense Bar, and the district attorneys, at least. And there are ways to do this, to share relevant data as much as law allows, so that we can have a meaningful evaluation plan, and that quarterly meetings could convene to troubleshoot challenges. So I've had some success in some of my prior roles pulling together large agencies for problem-solving sessions, and designed not to place blame anywhere, but to really center the particular patient challenge in the middle of the conversation, try to work collaboratively to figure out. I've really not ever met a system that can't wiggle its way around a problem. You just have to get people to be motivated to do it. And I would argue that because this is a relatively political thing, an academic institution would be the perfect host for a meeting like this, because in theory, you don't have any skin in the game. Okay, and that's where I'm going to close. Thank you.